So we're going to start the afternoon session off with, we're going to have 4 brief talks, and the first one is by Dr. Yi on precision medicine.
So I thought the song would be, the Sledgehammer song by Peter Gabriel would be apropos, since a lot of the treatments in oncology are sort of a sledgehammer type approach. And where the field is shifting is incorporating more, more precisely targeted medications. Not to say that a sledgehammer isn't appropriate in some situations. So, and as we heard this morning, multiple myeloma, even though we tend to view it as a single diagnosis, it really is a heterogeneous composite of diseases. And I mean, some of this is already clinically evident in some patients in the audience. When they presented with disease, they present with bone lesions, and other patients present with low blood counts, or some patients present with kidney dysfunction, and some patients have some combination of above. So the field and our goal is to try to come up with more precisely targeted medications. So, for example, just thinking more broadly, take, for example, lung cancer. We tend to view lung cancer as sort of a single diagnosis, but it turns out that some patients have, for example, patients who don't smoke have mutation-specific types of lung cancer, and knowledge of that has really been a game changer for patients who have, for example, EGFR mutant lung cancer, just to provide one example. So what we're trying to do, what the field is trying to do, is try to adopt similar principles and try to bring them into the multiple myeloma field. So, we've seen this slide already how the initial diagnosis, we talk about the fish in cytogenetics, but there's actually a whole lot more under the hood that remains to be explored, and that's where these newer diagnostic modalities such as sequencing play a role. And so here's one example. We have 2 patients, and on paper they both look very similar, and the cytogenetics or the fish both show similar findings, but yet one patient has disease that's very aggressive and only a short period of disease control, whereas the other patient has a longer period of disease control. And the key to understanding the difference between these 2 patients is by doing sequencing. So if you do sequencing and you look really deep under the hood, in the patient who had aggressive disease, this patient had a mutation in P53, and the other patient had wild-type P53. And presumably, that is what could have potentially made all the difference. So the MMRF is spearheading a drive to incorporate this kind of comprehensive molecular understanding of the disease through the COMPASS study. I'll try to go fast since time's limited. And through the COMPASS study, the COMPASS study has identified potentially actionable mutations in a good chunk of patients. In particular, I'll focus on this BRAF mutation, which is the red slice of the pie. So, and the reason why that's important is that BRAF is part of the signaling cascade that drives growth of cancer cells, and in some cancers, in BRAF are associated with, or the driver mutation in the cancer. So the best example of that is in melanoma, where about 50% of patients with melanoma, the skin cancer melanoma, have a mutation in BRAF. And targeting that gene specifically with a drug that targets BRAF by itself and not necessarily other genes, so hence the precision medicine, has been a game changer for melanoma. And now we've recently discovered that in some proportion of patients with multiple myeloma, so in this patient, for example, targeting that patient with the Dabrafenib, which is a BRAF inhibitor, which is FDA approved, has made a significant difference for this patient. And I think, and also notably too, this is just Dabrafenib. We're not like sneaking in some steroid on the side, okay? It's just Dabrafenib. So, and then I know that there's some questions about Venetoclax. So this is another example. So in cancer, there's an abnormal balance between cells that promote cellular survival and signals and pathways that promote cellular death, right? So normally there's a balance between that. But in cancer happens to hijack the pro-survival signal. And the BCL2 is one of the players that is involved in this aberrant pro-survival pathway. Now, it turns out that Venetoclax is a BCL2 inhibitor, and that disrupts that. And in some cancers, it's been it's been a significant improvement. So, for example, in chronic lymphocytic leukemia, Venetoclax has been FDA approved for that disease, and it disrupts this whole pro-survival pathway from BCL2. And the key here is that we can apply similar understanding to multiple myeloma. So, in a trial that looked at patients with the T1114 translocation, they found that patients with T1114 translocation had an unusually high response rate to Venetoclax. So why this is important is that Venetoclax is an off-the-shelf drug. It's already FDA approved for chronic lymphocytic leukemia. We already understand some of the safety signals of the drug. So this is a drug that is sort of like shovel-ready, ready to go. And the key is to identify the patients that could potentially respond the best to this drug. So this T1114 translocation, it turns out that T1114 translocation happens to be associated with increased BCL2, reliance on the BCL2 pathway. So, and this motivates an ongoing trial looking at Venetoclax in combination with bortezomib and dexamethasone that you heard about from Dr. Berenson. So, one direction where we're moving forward is taking patients and doing comprehensive molecular profiling, and based on the results of the molecular profile, try to come up with more precisely targeted therapies. So not the sledgehammer approach, but more precisely targeted therapies. So you can see here, depending in this proposed protocol, depending what mutation you have, there's a particular drug that's associated with targeting that pathway. And here are some additional examples. So one example I'd like to point out is a trial of Dabrafenib and Trametinib, which is being led by our institution. And that is looking at patients who have BRAF, NRAS, or KRAS mutations, which is about 20 to 30%, maybe even higher proportion of patients. So in patients who have a BRAF, KRAS, NRAS mutation, based on what mutation you have, you get randomized to, say, Dabrafenib by itself or Dabrafenib and Trametinib. And similar to the Venetoclax or Vemurafenib, Dabrafenib and Trametinib is already FDA approved. It's ready to go. It's FDA approved in melanoma, and what we're trying to find out is, can we apply the same approach and identify patients with mutations and come up with specific targeted therapies? So I think, moving forward in multiple myeloma, there will probably be a balancing. Some patients may need the sledgehammer approach, but then other patients, we might be able to do a more targeted, focused approach. And I imagine moving forward, there'll probably be some combination of the two, and the key to that will be to do comprehensive molecular sequencing to better understand the whole molecular profile for every patient's individual tumor. So I'll stop here.
How quickly do you think we'll be able to use the genetics for specifying treatment, and how quickly do you think that'll be translated to companion diagnostic and label? Do you have any thoughts?
Right. So I think the key is, one, having access to the testing to do this kind of molecular profiling. So at our institution and also at academic institutions, it's more widely available. It's more widely incorporated into the diagnostic algorithm for evaluating a patient at time of diagnosis or at time of relapse. We routinely do a molecular profile to look for, let's say, BRAF, NRAS, KRAS mutations. And I'm not sure if that's widely available or not through reference laboratories as part of their testing portfolio, or if that is something that needs to be specifically requested. The second question is, when will this be incorporated into the part of the routine framework in multiple myeloma? And I think that as we discussed with patients who have relapsed refractory disease and how drugs are approved and how they're tested, we start off with patients with relapsed refractory disease first, where there's more of a need, as opposed to patients who are newly diagnosed. So suppose if I have a patient with newly diagnosed, a patient with BRAF mutation, for example, I still would use the RBD as the upfront approach until it was shown that using BRAF inhibition upfront leads to an overall improvement. So that's the key thing, is that before all these new therapies are really exciting, but we like to do clinical trials to better understand more rigor, because theoretically I could just right now just prescribe somebody, Vemurafenib or Dabrafenib or Trametinib, right? It would be off-label use, and if the insurance company applied it, I could just do it up front or at relapse. But I think the key is clinical trials to better understand, is what we think it does really doing what it's supposed to do? And until that happens, then I think it'll be more widely used.
So our next speaker is going to be Dr. Chari.
Minimal residual disease, because this is a really exciting thing to be talking about. We've gone from, SPEP to UPEP to light chains, and this is the next era. And you've heard a little bit about this throughout this morning's program. So what is MRD, minimal residual disease? What we know so far is that getting to a complete response where we eradicate those proteins by the various testing does not eliminate all the myeloma clones. This is important. Another interpretation of the term multiple myeloma is there's multiple clones in a given patient. Although we conventionally think about it to distinguish solitary plasmacytoma with multiple plasmacytoma, myeloma is really has a lot of clones. And per Dr. Yee's talk, one of the limitations of doing precision medicine is if you're only treating one clone, what about the rest of the disease? And so we need to understand as our treatments are getting better, our diagnostic treatments modalities need to keep up with these advances in therapy. And so as per the iceberg analogy that I used earlier, we want to go not only just getting rid of crab symptoms, getting rid of the protein, but getting to those deeper levels. And technically, at the current state, we're looking for less than 1 in a million cells. And that's shown here on the left. You start with a very high burden in the marrow, and as it comes down, you get lower and lower, and eventually to be below the MRD positive and convert into MRD negative. This is also important because we're all here because we hope, as we heard, that we'll all be out of jobs, but that means that we have to go for cure. To do cure, we need to get that sustained MRD negativity, and that's an important point about MRD as well. We often talk about MRD at a single time point, but the sustained nature of MRD is equally important, because if you have MRD at one time point and you lose it, that's not a cure. So to really get towards the goal of a cure, we need sustained MRD negativity. So what are the limitations of MRD? And so I'll start with what's at the bottom, which is, remember that currently when we're talking about MRD, these are done from a single bone marrow biopsy and aspirate, typically the liquid that comes out of the aspirate from the bone marrow sampling. The problem with that is, what if a patient, you've heard some examples already, but what if a patient has primarily disease in discrete parts of the body, but not uniformly throughout? And so there are reports from different institutions that up to 10 to 15% of patients can have focal disease on imaging, but be negative by MRD testing. So we don't want to put all our eggs in this one diagnostic test. So it's important to not only get all the blood tests to be negative, but also have negative imaging, and then we go to the marrow. So that's an important point that we need to think about. But the future, we hope, will be better than what we have now. I'm sure you'll all be terribly disappointed to have to forgo having marrows, but the future is to do these tests by circulating. So from the blood, looking at circulating tumor DNA or tumor cells. And there's been a lot of advances in picking up microscopic amounts of DNA as well as circulating plasma cells. Compass actually looked at that already and showed that patients who have a lot more circulating tumor cells tend to do worse with respect to current therapies. So we hope that we can get to the point in the future where bone marrow biopsy will be obsolete. But right now, these are the techniques that are being worked on, and we still have the limitations of the marrow. So what do we know so far in treatments? You've heard both in what I was discussing about RVD induction and Dr. Krishnan's talk about RVD and transplant timing. And whether patients were assigned to RVD or transplant, you can see that the patients who were in blue and were MRD negative did better with respect to progression-free survival and depth of response. So the deeper the response, the better they did, and then those who were positive did worse. One of the questions that obviously we all want to know is, well, if patients with RVD who are MRD negative do so well, do they need to go to transplant? And that's a question that really, unfortunately, we don't have large numbers of patients. The likelihood of getting to MRD negative was much higher in the transplant arm. But the hope is in the future, if we can get better validated tests, if somebody got RVD and was MRD negative, can that patient reasonably forego transplant to a future date because they're doing well? So that's the kind of question that we want to be able to answer, and these technologies will help us get there. When we look at all the published studies, and again, you heard about this term meta-analysis, where we pull those all together, there were a total of 15 studies, and out of those, 14 studies. In every single one, MRD negativity correlated with progression-free survival and overall survival, which is great, because that's what we want. We want a new test that's going to help us predict outcomes better than what we already have. But an important bullet below that is that out of these 14 studies, only one study showed a predictive value in unfavorable cytogenetics. What does that mean? It means that patients who are high risk If they're MRD negative, it doesn't mean the same thing as a low-risk patient who's MRD negative. So that molecular risk, the genomics that you heard about from Dr. Cole, that still makes a difference. So that's very important because even though we want to get to negative responses, it doesn't mean for a high-risk patient, MRD negativity means you can just back off and stop therapy. The question, of course, would be in low-risk patients, is that something to consider? But the fact that molecular risk still matters tells us that the MRD testing is not an end-all and be-all yet. So how would we summarize what the role of MRD is in practice? So what are the benefits? We talked about its prognostic information. Negativity clearly correlates with clinical benefit in terms of the duration of myeloma remission and how long people will live. Combination therapies with the novel therapies, particularly new immune agents, can now attain MRD negativity. I can tell you that there's a lot of interest in using MRD for drug development because you've heard, for example, from that study that compared early versus delayed transplant, we didn't see any survival difference at 4 years. Well, if patients with myeloma are living longer and longer and we're trying to do new treatments, how long are we going to wait for these studies to be followed before we can tell if a new treatment's working? So that's where we can start using MRD, not necessarily in heavily treated patients where what's much more important than MRD is really how long they're going to be in remission. But as we go earlier up into maintenance and newly diagnosed patients, patients are doing so well, we need new technologies like this so that we're not waiting for 8 years to get the final results of a study. So that's probably where we're going to see MRD first get approved and used. What are the precautions? Technology always sounds kind of boring, but let me try to explain why this is so important. The sensitivity of the test can be really different. For example, the two large modalities, one was you've heard a little bit in these slides where the next generation sequencing by PCR, but you can also do it by flow cytometry. But the problem with flow cytometry in particular is that it really depends on the quality of the aspirate. So when you pull out an aspirate, if you get a lot of blood contamination, that's going to dilute the sample. Then by the time it gets from the draw of the patient to the laboratory, myeloma cells die pretty quickly. So if it takes more than a few hours, you may lose viability. When it gets to the lab, they have to decide how many cells they're going to count. If one lab counts more cells than the other one, you're going to get different results. And finally, within each cell, how many antigens or proteins are you going to count? When you have so much variability from start to finish, you can imagine, and I think the best way of explaining why this is so important, you all know about the hemoglobin as being a measurement of anemia. When you go to one institution, if you go to Dr. Berenson and City of Hope's, they're going to give you approximately the same hemoglobin of 8 to 9 if you're anemic. With MRD, it's quite possible that if you take one aspirate from a patient, send it to 2 different labs, done at 2 different institutions, you may get differing results, especially when we're getting to these very, very low levels. So when we start basing our treatment decisions on tests that are not yet completely validated, it can make us start spinning because we're going to be changing on the basis of inaccurate information. So we really need to do a better job of standardizing across labs. We need to also be able to apply it to each patient. So while the next-gen sequencing doesn't have a lot of those limitations that we talked about with the flow, the problem is that you need an initial clone to diagnose somebody with MRD. So for example, if somebody's a relapsed patient, but they never did their initial clonal testing at diagnosis, they won't be able to determine whether that patient's myeloma clone is still there. So each technique has its pros and cons, and so then we have to figure out what is the best putting that all together. You heard already about the importance of the limitations of MRD in high-risk patients. And so what are the unanswered questions? As I alluded to earlier, any test that we do should affect our treatment in some way. If we're just going to look at it and say, okay, that's nice, then why would we do the test? Every test is going to add cost to the healthcare system, and if it's not changing therapy, it should be reserved for research. But the questions that we all want to know about, obviously, are if somebody's MRD positive, should we be intensifying the therapy to get them to be negative? And that's a question. So far, a lot of the studies that you saw are all just correlating, but there's not a treatment adaptation yet. So we would want to know that if you had MRD positive, you signed half patients to more intensive, half didn't. Did it really make a difference? Because the equivalent right now would be in somebody who's in a complete remission, their immunofixation becomes positive, which means that we can now detect the band of myeloma. Many of us aren't treating those patients. Just because they're positive, we're going to follow them because it could be months to a year before that causes any symptoms. And if MRD is going to predict that even earlier, we may be adding a lot of therapy before we have proof that it's going to help. Should we stop therapy or de-intensify if MRD is negative? That's equally important because every myeloma study to date is usually designed to treat to progression, meaning we don't stop therapy. We need to get to a point, especially for low-risk patients, where we can say, you know what, you're doing very well. You have sustained MRD negativity. Let's talk about the possibility of stopping therapy and seeing how you do. And then the last thing, as I kind of alluded to, was if somebody was MRD negative and they become positive, we really don't know when and if treatment should be started. So I would summarize by saying there's really exciting preliminary data. We need this type of test to get to these more deep levels of response assessment, particularly for earlier stage disease. But right now, it's still limited to clinical trials, and in routine care, the utility is not completely understood. Thank you.
We had a couple questions I think we have time for. One of them is, what's the best MRD test? And the second is, when will MRD testing be FDA approved?
Okay, so the two leading tests are the flow and the sequencing, and I think they each have their pros and cons, as I alluded to. So the flow has the advantage of you don't need a primary clone. So even if you didn't get that initial marrow and you are doing a post-transplant assessment, you can be assessed by flow. The limitations are all those issues I brought up about the generalizability, the reproducibility. The PCR has the advantage of not having that viability issue, the time to getting to the lab, how many antigens, how many cells. So a lot of those are eliminated, but you need that initial marrow to find the clone and then be able to produce it. Both are being pursued. Some groups in Spain particularly are very pro-flow, and there's efforts in the US of doing both. I can tell you New York State, the New York State is very cumbersome in terms of getting anything approved. We cannot even order the next-gen sequencing because it's not yet certified. So we're working with the company that's doing that, one of them Adaptive, to try to send them samples. So you can tell, like in New York, we really don't even have the second option. So it tells you how limited the data are. And when will these approved was the other question. My guess, and this is supposed to be panel discussion, which is why I was sitting down. My guess will be it'll probably be at least another year to year and a half, but it's worth just mentioning, too, that we should give props to the FDA, which you rarely will hear people do. But the reason for that is most oncology studies are approved on the basis of overall survival, right? You need a phase 3 study to say A versus B. People live longer with A, therefore let's approve A. The FDA has gone from that to now accepting progression-free survival, that Group A myeloma remission was better. So that's an improvement because then you don't have to follow patients as long. This would be the next iteration of that, which is you don't have to wait for the remission duration, but you can use MRD negativity. So it has a lot of potential impact on how drugs are going to be approved, and the FDA is actually very interested in it. We've had several meetings with them. They are open to this, and they're looking at this as a surrogate endpoint because as people with myeloma are living better and better, longer and longer, we need these newer techniques. And so the FDA has been very involved, and all the companies that are doing this work are closely communicating with the FDA as well as with the academic institutions. So.
All right, Dr. Cole is going to tell us about maintenance therapy.
Oh, there really isn't a lead-in to that song. I just love that song. But it is kind of sort of don't stop believing about maintenance therapy. And I kind of have the easiest job because 5 years ago when we were doing this meeting, it was really, it was really like the first two speakers where it was people were asking, should I be on maintenance therapy? Is there enough data for maintenance therapy? And now the questions are what should we do with MRD? So this is the story of maintenance therapy is actually the maturity of the data and the clinical trials that people have gone on because now we have a level of certainty about what maintenance therapy can do. So the first question is what is maintenance therapy? And it's a prolonged, often low-dose form of treatment that is given after an initial therapy. So after a patient has received their diagnosis, they've gotten their initial therapy, maybe plus minus transplant, the therapy that is the cruise control that they stay on is a maintenance therapy. And the goal of maintenance therapy is to try and prevent progression, so prolong the time till the disease comes back, while, very importantly, while maintaining a favorable quality of life. Now, maintenance is a little different from consolidation. There have been speakers, and I'll talk a little bit about consolidation. Consolidation is what is a bit more intensive than maintenance therapy. Consolidation is a shorter course of usually higher dose therapy to try and bring down the protein more or bring down the disease more, and then maintenance follows that. Lower dose therapy, easier to take for long-term purpose to keep the disease at bay, if not have it decrease very slowly. So if this is the initial therapy, so RVD for a lot of people, or Revdex, the next thing is consolidation, which is many times transplant or stem cell transplant. And for patients who don't opt for transplant, usually continuation of their initial therapy. And then there is maintenance, and maintenance is initiated veritably in consolidation after initial therapy, and usually after transplant, maintenance is initiated. And again, the point of that is to push out relapsed disease way out into the future, and even further out, somewhere over in Toledo, Ohio, which is, I think, somewhere over there. And so that's the purpose of maintenance therapy for both transplant and non-transplant patients, but also to continue supportive care and to make sure, again, the quality of life is good with the extension of the maintenance therapy. So can maintenance therapy prevent or delay progression? That question mark should be gone, because we know that it does delay and prevent delay disease progression. Does it convert partial responses to complete responses? That question mark is going to be erased in the next few weeks, in part that some of the studies that we've been doing on using other maintenance therapies, as well as Revlimid and Velcade, have shown that they're able to upgrade responses on a longer-term basis. And does it improve overall survival? I'll show you that we're going to erase that question mark. Those questions have been answered. But again, 4 years ago, these questions were very viable questions until we had the clinical trials to prove it. And these are some of the clinical trials of phase 3 trials where patients randomized between the best known care at that time versus maintenance therapy. There were a number of thalidomide trials, Velcade thalidomide trials, and 3 Revlimid trials that were transplant, and then maintenance therapy versus no maintenance therapy. And then there are trials that also had Velcade, thalidomide, and Revlimid trials that were again randomized between what we used to do, which was observation, versus maintenance therapy. And most of those trials showed progression-free survival. And fortunately, the one question is, well, we're going to develop new aggressive clones by people being on long-term therapy. And there was no evidence that there was any aggressive myelomas that occurred after people relapsed after maintenance therapy, which is good, because we don't want to make things worse. And then there was a lenalidomide maintenance after a stem cell study that looked at Revlimid maintenance and looked at it with 3 big, huge trials that had lots and lots of patients in it, where patients were either given Revlimid maintenance or placebo. Because placebo, back then in the 2004, 2005, was the standard of care. That's what we did. And Revlimid maintenance was something that was very experimental at that time. But with maintenance Rev versus placebo, maintenance Rev versus placebo, maintenance Rev versus placebo, lots of patients, the outcome was all the studies showed that lenalidomide maintenance significantly improved overall survival after stem cell transplant and prolonged progression-free survival. So with all those people in a randomized setting, it's really hard to argue against the benefit of maintenance therapy. And then the FDA had approved it because of just the amount of studies that showed this benefit. And so now it's approved by the FDA. There are, now that we know that maintenance therapy does such a good job in delaying relapse, in some cases deepening response, and improving overall quality of life, length of life, we still need to know about quality of life and still need to know how long we should do that. And there are two trials that have both been mentioned earlier today. The randomized trial between early stem cell transplant after RVD versus stem cell transplant at relapse. Both of those arms, transplant and no transplant, have maintenance Revlimid. And so it'll be interesting to see how long does it take these patients with maintenance Revlimid to end up getting a stem cell transplant when they have ongoing maintenance Revlimid. And the stamina trial was important. In fact, I think the next slide talks about the stamina trial, but also it showed the part with this is that patients got stem cell transplant, either got a second transplant, more RVD consolidation, or no consolidation, went straight to Revlimid maintenance. And this trial was important because all these arms were equal in their outcomes. So now a lot for patients that are very much like the patients enrolled in the stamina trial, we go from stem cell transplant directly to consolidation. And that was a big, big deal. Patients always, I'm still fighting with one of my patients who is saying that the Revlimid is going to cause secondary cancers. It's going to cause secondary cancers, and it does. It can cause secondary cancers. The secondary cancer risk was most evident in Europe when patients in Europe are usually given melphalan oral therapy for very long periods of time because they don't have the opportunity, they don't have the drugs approved like we do here, like Revlimid for induction therapy. So in Europe, patients were given long-term melphalan oral therapy. They then got a melphalan transplant, and then they got Revlimid maintenance, and there was a higher risk of secondary cancers. When they looked in the United States to see if that was true, there's not a lot of patients in the United States getting induction therapy with long-term melphalan pills. What we usually do is use Revlimid, Velcade, and Dex, or some combination thereof. They receive one dose of melphalan as their transplant, and then they go on maintenance therapy. And the secondary cancer risk is not as high as what was published in Europe, but it was the European data that had gotten us kind of, that brought it to our attention. One thing is that if you look at patients who received Revlimid maintenance or who didn't receive Revlimid maintenance, patients who did receive Revlimid maintenance, what was their chances of developing a secondary cancer? Very low, over 25 years, chances of developing secondary cancer being on maintenance Revlimid. The patients who didn't, so my patient who's saying, I'm not going to take maintenance Revlimid because of the cancer risk. Well, the risk of the cause of death other than secondary cancer in myeloma patients, i.e. myeloma, was much higher in patients who didn't take Revlimid maintenance. So when it comes to dying from the primary cancer or from the secondary cancer, developing a secondary cancer, very rare. In taking Revlimid maintenance, the chances of dying from cause other than secondary cancer, i.e. myeloma, much higher. Therefore, the FDA and all the myeloma doctors agreed that the risk of secondary cancers is definitely outweighed by the benefit of prolonged progression-free survival and overall survival by taking maintenance therapy. That doesn't mean that we shouldn't monitor for secondary cancers. My patients get mammograms, get colonoscopies. They see their primary doctor to look for secondary cancers. We do skin exams all the time in patients. And so we look for them and then act on them early, but we don't deny them therapy because of that worry. Again, the stamina trial was a fantastic trial where they looked at patients either getting induction therapy followed by transplant, and then they're randomized to either getting a second transplant or getting consolidation or just maintenance therapy. And again, maintenance therapy was equal to all those more aggressive therapies after transplant. But that study was a little bit limited, as you can guess. When it came time for those patients to say, hey, it's time for your second transplant, a lot of those patients said, maybe not. But it does show the importance of maintenance therapy. So now we have a lot of information on maintenance Revlimid, and that information is just growing and growing and growing. Now we need to know better when should we hold maintenance therapy. How long is the optimum time to receive maintenance Revlimid? Velcade is coming up, and in the next few weeks at the American Society of Hematology meeting, this little box of Nenlaro for maintenance therapy is going to bloom a little bit more as we're finding out more about maintenance on Nenlaro. But we still need to especially understand what is the quality of life. Because these therapies are not without their side effects. We need to know better about what can we make people's lives better while they're living longer with myeloma. So what we know, it keeps the disease away longer, improves overall survival, but there are toxicities. There's some, it can make the blood count slow, gotta watch for secondary primary malignancies, but the risk is low. And we need to look at quality of life, and we know that it costs a lot. What we don't know is, do all patients need maintenance therapy? And the thing that kind of drives me bananas a little bit is that we give everyone maintenance therapy. Does everybody need maintenance therapy? And some of the COMPASS data and some of the MRD data, that's all going to get married to help us tell who should be on maintenance therapy and who shouldn't be on maintenance therapy. What's the duration? Oh, we need to use, again, these fancy, new tools, wake up, to help us tell how long people should receive it, and the evolution-resistant clones we're looking at. And I think so maintenance therapy summary, lots of trials showing that it works for all the outcomes that we're looking for. Duration is uncertain. And we don't know who needs it and how long they should get it. And that's what we're looking for the future. And that's it.
Two questions would be interesting in terms of, we didn't talk about for the panel, what data is on carfilzomib as maintenance, and if so, what schedule, dose, et cetera, do people use?
Well, there's no data, obviously. We give once weekly, either day 1, 8, 15 or day 1 and 15. We've done it both ways, but there is no data. But we do it once a week, not twice.
There was a trial looking at carfilzomib Revdex for newly diagnosed patients where they got 4 cycles of KRD followed by transplant and then 12 more cycles of carfilzomib. But beyond that, there's nothing for extended use of carfilzomib.
I think the other interesting thing is we do all these studies with the durations as prescribed, but we've recently looked at a large database of real-world use, and it's shocking how much less patients are getting in the real world relative to studies. And it speaks to the generalizability of studies and, that we pick the best of best patients to go on clinical trials, but is that really feasible in the real world? And where there's fatigue and issues with getting to the cancer center. So we need to really balance the two, which is the clinical benefit with the quality of life and the reality of treating people to progression.
And I think that's what I completely agree in, that now that we know that it has these great benefits, we have patients living with these therapies now. And so, especially with Revlimid, and Revlimid can cause diarrhea, and Revlimid can cause fatigue, and of course, Velcade can cause neuropathies. And so I always tell my patients that it's like when I flew here from Detroit to Los Angeles, I need a really comfortable seat if I'm going to go on a trip that's that long, and I was really uncomfortable. And because the guy in front of me pushed his seat like as far back into my lap as he could. I could give him a massage if I really wanted to. And that's like terrible maintenance therapy, is being in an airplane and having the guy in front of you where you could massage his head, because it's uncomfortable for a long period of time. So the maintenance therapy we need to do, and as we look forward in new maintenance therapies, is something that is long-term, that is an easy ride. It's like having a private jet instead of having the cheap seats in Delta Airlines. But I love Delta. I'd love them.
And then last but not least, I think the hottest hot topic that is CAR T-cell therapy, and we have Dr. Tutt from City of Hope is going to speak to that.
All right, this CAR T-cell is really now a hot topic. Recently, FDA approved two drugs, one for a form of leukemia, another one for lymphoma, to approve this CAR T-cell therapy. So let me go about, a little bit about normal function of these T cells. So we have specialized cells in our body, what we call T cell, and they have a structure on their cell membrane that bind a part of the cancer cell. We call it antigen, and this is how normal T cell can kill off the cancer cell. But in patients with cancer, such as in myeloma, this process is not functioning that well. Patient's own T cells are not killing these cancer cells. So we modify this T cell to have a new receptor on their cell membrane that bind to the same antigen on cancer cell. We call it a chimeric antigen receptor because it is a form of receptor. It targets the antigen, and this structure came from different parts. It's like a Frankenstein. We call it chimeric antigen receptor. So this is the actual structure, this one. So the bottom part came from what we call T cell receptor complex. We borrow this part from TCR, and the upper part came from antibodies. These are the special kind of protein in our blood that kill off cancer cell and infection and so forth. So we borrow this part. So that's why it is called chimeric, because it comes from a different parts. And we can modify this part to bind any kind of antigen that is a target on a cancer cell, whatever way we want. If we want to target BCMA, we can modify that. If we want to target prostate cancer, lymphoma, lung cancer, brain cancer, we can change the sequence. So we can call these cells as like a designer T cell because you can design it based on your target. In addition to that, when we modify T cell, these T cells are patient-owned T cell, and when reinfused back to the patient, they can multiply in the body. So they can serially kill the cancer cell. So these are like designer T cell. If they work, they will be like a serial killer cells for the cancer. So this is the process how these T cells are generated. So first step is that we have to take patient's lymphocyte. So it is very similar to apheresis procedure that we do for transplant. Patients who already had transplant know that this process. So we take the blood out, let it go through the machine, and we just filter out patient white cell. This is number one step. After that, we send it to manufacturing facility. But for City of Hope, we manufacture our own T cell. Then these T cells are mixed up with some virus, what we call retrovirus, to express this new receptor. You can see this is the patient-owned T cell. This is a virus that we use, one of the retroviruses, and you can see this red receptor. This is a chimeric antigen receptor on this T cell. And then we grow them in the Petri dish for about 60 to 70 fold. Let's say we start with 1 million cells, we will end up with about 60 million cells. Then these cells are shipped back to the center for the treatment. And before we reinfuse these cells back to the body, we give what we call lymphodepletion chemotherapy. It is kind of like a chemotherapy that makes rooms for the newcomer, this T cell. And several days after this lymphodepletion chemotherapy, we infuse these cells like a blood transfusion. It comes with a little bag, sometimes only like about 50 to 100 mils, so very small volume. and the infusion will be over in like 5 to 10 minutes. These cells, they are like very new cells. These are like teenagers on steroids. Sometimes they can cause some toxicity. So the previous lymphoma trial showed that the patient can develop hypotension. They can develop problem with the breathing. Sometimes they do strange things to the nervous system. Patient can have seizures and things like confusion and things like that. Sometimes these cells kill, this new T cell kill all the cancer cells once at the same time. So all the cell debris are released into the circulation, and it can shut down the kidney and things like that. We call it Jumalysis syndrome. The more we do this CAR T cell therapy, the more we learn about their effectiveness as well as toxicity, and we know how to manage them. Very easy step is that when we give steroid, like a dexamethasone, it can ablate all these new T cells, but it can also ablate all the complications related to this T cell, these CAR T cells. So what are the possible targets? The ideal target for CAR T cell therapy will be that it is just limited to the myeloma cells. So when we give this T cell, there is no collateral damage, like we don't want to target the heart, we don't want to target the brain, and so forth. So these are the potential target, like CS1, it is universally expressed. More than 95% of myeloma cells have this antigen. The next one is a BCMA. It is present in more than 60%. And some people argue it is universally expressed if we do more detailed testing. And the good thing with these antigens are that they are just limited to the myeloma cells, and they are not expressed on other tissue like a heart, lungs. This CS1, for example, it is also expressed on normal plasma cell, likewise BCMA. So we look at these antigen expression in cancer cell line. One of them is what we call MM1S, and we saw that both of them are expressed in this cancer cell line. And we took some primary myeloma cell from a patient, and we check it, and we also see that some of the patient express both antigens. So this is an overview of current T cell trial for myeloma. The top one, the CAR T cell targeting CD19, it was published about 2 years ago. Myeloma cell doesn't really express CD19, but they are expressing precursor cell to the myeloma cell. So that's why CD19 was targeted, a very good response in one patient. There are about 5 trials targeting BCMA, NCI trial, UPenn, the one from China, and the Bluebird. So they all had some responses from 66% to almost 100%. Again, all these trials show that in about at least 60 to 70% of patients develop some toxicity. Most of them are manageable. And Juno Therapeutics will have this CAR T cell trial targeting BCMA. It will open at our institution, City of Hope, in about 3 months, something like that. And we also have our own CAR T cell trial targeting CS1. I will show you the data in a minute, and we expect that to open mid-2018. So we use healthy donor cells to modify and have and produce CAR T cell. So first step is that to see whether these CAR T cell can kill off the myeloma cancer cell. So we mix them up with some of the cell line, and we see that these CAR T cell kill off cell line that has expression of CS1. This is a bottom picture. And this is a gene sequence that we put into these retroviruses. So these viruses love a lymphocyte. So we have a technology to change, to insert that sequence of what we want into this retrovirus, which is like a carrier to put into the lymphocytes. Next step, we did the animal model. So this row these animals were injected with some myeloma cells, so they developed myeloma, and we can do some special scan. These red areas, these are the area of the myeloma. So this row is untreated. The middle row is mock. It's like volunteer T cell, but without any modification. You can see these two rows are very similar. In about day 28, the myeloma got really big. So the bottom row, we infuse CS1 CAR T cell. You can see that the myeloma gradually goes away. It doesn't mean that it will work in patient because we use immunodeficient mice, so it would be a different setting in human beings. And this graph shows the survival. This green one is the group that received the CS1 CAR T cell. The blue one is the mock, as well as the untreated. They have a very similar line of survival. After day 40, these two groups, none of the animals survive, and with this green group which received CAR T cell, they survive more than 80 days. So after that, we also did more testing to see whether we can potentiate these CAR T cells. So we gave lenalidomide to this animal, and we noticed that the group of mice that receive CAR T cell as well as the lenalidomide, they have the longest survival. And this is a schema of the proposed CAR T cell trial, and we would do the consenting bone marrow biopsy. It would take like a week. And this T cell manufacturing process lasts about 3 to 4 weeks. And during that period, we will allow patients to receive any kind of bridging therapy to control their myeloma. This is a lymphodepletion therapy, then T cell infusion. Then we will be serially doing routine blood tests, including the bone marrow biopsy. So this is a T cell team. You can see you need like a village to do this kind of trial. And Dr. Wang did all the preclinical trial. I would like to thank Briskin family for their support, and finally MMRF who funded grants for past 2 years to do this preclinical study. Thank you very much.